Good day, students. Welcome to R.A.T.S Against Time for students in pathology. A case scenario is given here. A 40-year-old male with a history of recent travel 5 days back came to the doctor with high fever and mild rigor. He had symptoms of cough with expectoration, which was purulent. The right side of the chest was dull on percussion. Can you guess the diagnosis? The X-ray showed these features. What is your diagnosis? So there are some red markings over here, and one entire section of the lung is appearing opacified, that is solidified. We call it consolidation. So what is your diagnosis? Welcome. If you have made the diagnosis of a pneumonia, then how confident are you in answering the following questions? What is your diagnosis? Discuss the etiopathogenesis, morphology of the different stages. And what should be the differential diagnosis that should be borne in mind? Have a clear concept of this before jumping into the fray. So the class today is on pneumonia. In fact, there will be 2 sessions of these. And pneumonia by itself is a must-know question. It is an essay question or even a short note, short essay. The gross, microscopy, etc. can be asked. Very important in viva voce. You may have a specimen of it also. And any number of MCQs also can be asked. So we go into the pneumonia proper. Definition. Pneumonia is defined as an inflammation of the lung parenchyma. An inflammation of the lung parenchyma. Parenchyma means it does not include the pleura. The inflammatory exudate results in an area called consolidation. Consolidation. Before we go into the topic further, what are the normal defense mechanisms that we have got to avoid such infections? One is a constant mucociliary clearance. The upper respiratory tract as well as the trachea are all lined by this. A cough reflex, whenever there is an irritant, it is coughed out by means of this reflex. And there is an alveolar phagocytosis. So there are the mechanical factors, things are being filtered, mucociliary apparatus is there, and then also you find that whatever goes in comes out, an aerodynamic filtration. At the other end, we have got the alveolar sac, and in this alveolar sac, please see these cells. One is a neutrophil, another is an alveolar macrophage. Third one will be the lymphocytes, which will be producing the immunoglobulins. And this is a diagram of the bacillus that is entering. Obviously, you can enter the and see that there are multiple factors that will defend, and it is a capillary from which you get this. This is a schematic representation. One, it says that there are too many branches, so the particle cannot go in very straight. Second, as we had mentioned earlier, there is a ciliated epithelium, mucus, which cause a clearance. Third one, at the alveolar level, you will be having the surfactant, various complement systems can come into action, immunoglobulins will be produced, and the macrophages and neutrophils, which we had seen in the previous slide. So this is the basic defense mechanism that we should have in mind. Pneumonia itself is classified as, classification is an aid to orderly thinking. There is an anatomical classification. Define pneumonia, classify pneumonia will be the question. Under this, we have got a lobar pneumonia and then a bronchopneumonia, also called lobular pneumonia. Third one is the interstitial pneumonia. Lobar, broncho, interstitial. Three types of pneumonia anatomically. Etiologically, depends on the causative agent. You find that the pneumonia can be bacterial, viral, mycoplasmal, or fungal. These are the various causes. The individual organisms we shall see if time permits. There is another type also called as aspiration pneumonia. That also will be dealt with in a later session. So these are the various causes. We have got the anatomical classification and the etiological classification. The organisms are pneumococci. It is also called as Streptococcus pneumoniae, in which the types 1, 2, and 3 are there. The 3 is supposed to be more virulent. Pneumococcus. Klebsiella pneumoniae, Haemophilus influenzae, and Pseudomonas aeruginosa. These are all various bacteria which can cause a lobar pneumonia. And why do I say it's a lobar pneumonia? This pink color is a lobe that is totally involved. Since the entire lobe is involved, we call it a lobar pneumonia. It involves the entire lobe. Sometimes even more lobes can be involved, and occasionally an entire lung can be consolidated. It occurs in young and middle-aged individuals who are otherwise well-built. They do not have any predisposing conditions. But the organism is highly virulent. Organism is highly virulent. This is the lobar pneumonia. And see what is happening over here. This is the alveolus and this is the lung. In the alveolus, there is an interconnection between the adjacent alveoli. These are called pores of Kohn. Pores of Kohn. And bronchiola alveolar. Bronchiole is here and alveolus. Bronchiola alveolar. See, this is another form of interconnection. And interbronchiolar. Bronchiola alveolar is the canals of Lambert. And the interbronchiolar is the canals of Martin. So these are the interconnections, and you will understand why I am explaining this. And this is exactly happening microscopically. This diagram is just to show you a scheme. The different alveolar spaces are filled with exudates, producing a consolidation. And how did this happen? We had explained in the previous slide that one focus leads to spread elsewhere. And in this one, you find that there are two types of pneumonia basically. One is a lobar pneumonia, another is a bronchopneumonia or a lobular pneumonia. The entire lobe is involved, and here it is patchy areas of consolidation. All the deep pink colors are the consolidation, and the slight violetish color is normal. Bronchopneumonia and lobar pneumonia. Now, what are the clinical presentations? We had seen in the case history. There is a high-grade fever. In fact, the patient has a fever with rigor. My professor used to tell me that there are a few conditions where the patient can present with rigor. One is a urinary tract infection, two is malaria, three is filariasis, and four is pneumonia. He has a cough with expectoration, and there is no feature of a pre-existing condition in a lobar pneumonia, and the chest will be showing an opacity involving the entire lobe, and it responds well to antibiotics. That is the advantage of a pneumonia. It responds well to appropriate antibiotics. These are the clinical features. And the stages are, you find that there is a stage of congestion, red hepatization, gray hepatization, resolution. In addition to that, there can be a slight complication called organization. So these four are the stages, and this is a slight complication. So stages of lobar pneumonia. The first stage is the stage of congestion. It occurs in a period of about 24 hours. Usually it is not noticed because the time is very short, and it is rarely seen histologically. And what we are finding is an engorgement of the alveolar capillaries. The capillaries are becoming engorged, and there will be numerous bacteria that are there. The patient has inhaled and they have started multiplying. The defense mechanism is also starting to be in action, but initially there will be only a plain fluid with numerous bacteria. And the lung is boggy, subcrepitant. Crepitant means it will make a noise. Subcrepitant means not so clear. It is boggy means heavy. Stage of congestion. So remember this, the bacteria are the pneumococcus, alveolar capillaries, then there is an edema and polymorphoneutrophils trying to come inside. The stage of red hepatization. This usually lasts for about 3 to 4 days. The capillaries are congested again, and the alveoli are filled with RBCs. These are the RBCs, and numerous bacteria will be seen in the alveolar spaces. This is a microscopic picture, and grossly you find that the lung is heavy, it is red in color, solid, liver-like in consistency. So lung is heavy, boggy, and brick red. Alveoli are filled with bacilli as well as numerous RBCs. This is the stage of red hepatization. It is called hepatization because it is liver-like. Gray hepatization. Instead of the RBCs, you find that the WBCs start coming inside. So the color changes. Microscopically, you find numerous neutrophils will be there and fewer RBCs. The bacteria are killed and fibrin is being produced. This is an important feature. You find that there will be an area of clearance around it. So this is the inflammatory infiltrate, and there will be fibrin production. Because of that, there will be contraction, and the alveolar space will show a peripheral area of clearance. The inflammation spreads from one alveolus to another along with the infection through the pores of cough. The lobe is firm, boggy, dry, liver-like in consistency. The other features are all shown here. This is an actual microphotograph. You find that one alveolar space is filled with numerous neutrophils, and they are spreading to the other adjacent alveoli also. And this is the alveolar septa. It is showing congestion of the blood vessels. This is a stage of gray hepatization. In the gray hepatization, the solid feature will be, the gross feature will be, you find that the entire lobe is solid, gray, liver-like. It is consolidated, heavy. Normally a lung is not that heavy, but here it almost weighs like a liver-like in consistency, and gray-white to gray-brown in color. See, the entire lobe is involved, hence the term lobar pneumonia. And the fourth final stage will be the stage of resolution. Resolution means healing completely. So look at these alveolar spaces, no inflammatory infiltrate, and they are almost becoming clear like a normal lung. It takes about 5 to 6 days and the lung reverts back to normal. Alveolar sacs are air filled and all the debris that are there, they are all coughed out. This is a stage of clearance. As I mentioned earlier, there can be a complication. Any inflammation, there can be some amount of fibrin that is being produced. And when it is abundant, you find that it fills the alveolar sac, and that is called organization. Organization means replacement with fibrin. This can be seen in other lesions such as the thrombus also. Macrophages are there and it becomes a permanent residual lesion. It will not be cleared. Now, what are the complications of pneumonia in general? There is a cough with expectoration. Patient has fever with rigor. Sometimes it can result in a localized abscess. Spread of infection through the blood can lead to a septicemia. Spread to the thoracic cage can lead to an empyema. Meningitis is one of the important complications. Organization we have mentioned earlier. Death is very rare because with the advent of antibiotics and early diagnosis, treatment is good. Complications are cough with expectoration, febrile illness with rigor, abscess formation, septicemia, meningitis, empyema thoracis. Sometimes there can be organization. Rarely there is a death. The summary is the patient is young to well built and the organism is highly virulent. It is usually a pneumococcus. The entire lobe is consolidated. It spreads from alveolus to alveolus through the pores of Kohn and the canals of Lambert. The fever falls by crisis. And sometimes there can be complications such as empyema and infective endocarditis. Telescoping is one. I mentioned that there are 4 stages. Stage of congestion, red hepatization, gray hepatization, and resolution. You will not see all these stages. In fact, one merges rapidly into another with the advent of antibiotics. So within a period of about 5 to 6 days, the patient will become totally normal. So that is called as telescoping. The investigations that can be done, obviously a chest X-ray, that is what we had seen earlier. Sputum can be taken for culture and sensitivity. Sputum for acid-fast bacilli. Any cough with expectoration, this is mandatory. And if the patient has got any history of tuberculosis, relevant investigations will have to be done. This is a summary. I would like you people to memorize it and then write it, please. Congestion, the period is mentioned, the lung is heavy and boggy, and it is filled with exudate. And red hepatization filled with erythrocytes and fibrin. Liver-like in consistency, red in color. Gray hepatization, you find that neutrophils will be replacing the RBCs, abundant fibrin, and then a clear area around the infiltrate. Resolution takes about 5 to 6 days. Normal architecture is restored due to enzymatic digestion. This is a summary that you must write and it will definitely fetch you 80% marks. And these are all the features that we had seen. I will not be repeating it again. And for differentiation, there is a bronchopneumonia, which we will be seeing in the next session. So these differences you people can go through, and when I come to the next session, you people will be able to recollect them. Ευχαριστώ. Gracias, Tibi.